First, I should apologize. I'm a bit sniffly because of all the birch pollen in the air, which sets off my allergies. So I promise I'm not infectious. It's just my body overreacting to natural, totally harmless substances, which happens every year. It's nice to be here. Usually when I come to the University of Bristol campus, I go next door to the Merchant Ventures building, which is where the PI for the AI for CI hub is. So I've been past this building like a zillion times, but never actually been in. So it's kind of cool to actually come into this place. Today I'm going to talk to you about interpretable machine learning to detect psoriatic arthritis, and we're going to use electronic health records to do that. So as you'll see, psoriatic arthritis, I'll tell you a little bit about it, but it's a form of arthritis, as it says. It's kind of tied to the history of Bath. So Bath has a long history in medicine of treating sort of conditions of bones and joints, really dating to the fact that we have the Bath Spa there from the Romans. So there was this hospital, the Royal Mineral Hospital, which transitioned in being the Royal National Hospital for Rheumatic Diseases, of which psoriatic arthritis is one. So it's kind of cool to be so tied to actually being in Bath, the place. And so this is part of a long-term collaboration I've had with some rheumatologists at the university and a group of, I guess, epidemiologists and statisticians who specialize in these large electronic health records databases. So first, what is psoriatic arthritis? So it's a progressive inflammatory arthritis associated with destruction of the joints. So this is in contrast to, say, osteoarthritis, which is much more common, which was more about sort of wear and tear as you get older. So this means your immune system is sort of overreacting to something and attacking your joints and connective tissues. It's not a particularly common disease in the general population. So you may have heard of, say, rheumatoid arthritis, which has some overlaps, which is more common. But so psoriasis is fairly rare in the general. Psoriatic arthritis is fairly rare in the general population, but is fairly common in people who have the skin disease psoriasis. So psoriasis are these scaly patches that people get on their skin, which also is related to the immune system. So it's like an inflammatory skin disease. And a fair chunk of people who have psoriasis, which I'll abbreviate PSO, go on to develop psoriatic arthritis, which I'll abbreviate PSA. So the motivation for this research is that psoriasis is often treated in primary care. A lot of people don't necessarily need sort of heavy-duty treatment for their psoriasis, which would require them to go see a dermatologist. Many people can be looked after by their GPs, maybe with topical creams, like topical steroids or other treatments. But psoriatic arthritis needs to be treated by a specialist in secondary care, so rheumatologists specifically. So we need to help somehow these GPs who are pretty good at looking after people who just have the skin disease psoriasis decide, right, it's time for you to go see a rheumatologist because you may have this more severe joint-destroying thing called psoriatic arthritis. And it's really important that they do that in good time. So there's some research from the group at Bath has looked at delays to diagnosis, and even short delays to diagnosis of sort of 6 months or so can really lead to this irreversible damage to the joints. And these delays to diagnosis are really common right now. So what do I mean by damage to the joints? So here's a picture of what psoriatic arthritis can do to your joints, your small joints in your fingers. So when you have disease, you have if you have active versions of disease, you have all of this inflammation at it can be any joint in the body, but often it's in the small joints in your fingers and toes, and they can erode the bones. That's what we're seeing here, or it can also add sort of blobs to the bones, but essentially it's damaging and disfiguring these joints in the hand. And in other parts of the body, but kind of you can see this in people's hands, and then that leads to poor quality of life. This is irreversible damage. We want to be able to pick up people who are at the early stages of this disease so that they can be given treatment that can sort of slow the process that we're seeing the results of in this picture. Okay, so if detecting PSA was easy, I wouldn't be here, so obviously it's hard. So why is it hard? So symptoms of psoriatic arthritis are really generic. Joint pain, swelling. Swelling in joints is maybe a little bit less common, but lots of us have pain in joints here and there as we get older. Joint stiffness, fatigue, these are very, very generic symptoms. And the other issue is that lots of different joints can be involved. So I showed you hand joints, so sort of swelling in one finger is kind of herald for psoriatic arthritis, so that might be easy to pick up, but also some people have sort of spinal involvement. And as we get older, lots of people have back pain. So is it just regular kind of middle-aged person back pain, or is it psoriatic arthritis back pain? And it's hard for a GP to be able to distinguish between these things. And it can also, so it can often be misdiagnosed as a sort of more plain vanilla version of arthritis, just the osteoarthritis that many folks get as they age. So there have been some efforts to create tools that can help GPs screen for psoriatic arthritis in their patients that have psoriasis. So one here is called PEST, probably can't read that in the back, but there's 5 questions that are pretty easy to ask a patient in general practice. Do you have swollen joints? Has a doctor ever told you you have arthritis? Do your fingernails or toenails have holes or pits? So that's a sign of more severe arthritis when it starts to affect your nail beds. And it can be related to the joints that are close to your nail beds. Have you had heel pain? Have you had finger or toe that was completely swollen for no apparent reason? So these are questions you can, like a GP can ask their patient, and you score how many yeses you get. And I forget what the threshold is, but if you get above some threshold, it's a sign you should perhaps refer that person to a rheumatologist who can look for PSA. There are some more sophisticated. There's some more sophisticated research going on trying to develop risk calculators using some sort of bit more sophisticated statistical modeling. So this is a tool called Presto from some folks in Toronto that are looking at predicting risk of psoriasis going forward. So not screening, not looking for people who do have psoriasis at the moment, but looking to predict someone who doesn't have psoriasis. What are the chances that they develop in the next? They have 2 calculators, 1 year and 5 year. These are, again, some questions that are pretty easy for a primary care physician to ask. Do you have a family history? Do you have back stiffness? Again, nail pitting, which we see over there. Use of biological therapy, that would be an indicator of more severe psoriasis. This research is quite interesting, but not necessarily but it has some flaws. So they were looking at a fairly specific cohort of patients that may not be representative of all patients being looked after in primary care. And the other thing is that they had a kind of small sample size. So psoriatic arthritis is rare, so you need quite a lot of patients in order to get a good sample size to do some kind of more sophisticated machine learning things. So I think it's an interesting model to look at, but for example, they weren't able to kind of capture nonlinearities or interactions between the different predictors in their model. Okay, and I suppose inherent in this, missing from this whole list is there's no like one specific blood test you can do for psoriatic arthritis. So if you are familiar with rheumatoid arthritis, you can look for a particular so you can look for rheumatoid factor. Other things like lupus, you can look for certain autoantibodies, and if you find them in someone's blood, okay, they probably have lupus. But there's no such. At least we haven't yet discovered something like this for psoriatic arthritis. So it really is just these kind of general things that can help us distinguish between people who can just have psoriasis and then have a more severe version. Okay, so where do we come in? This research is part of a project called PREDIPSA, so predicting PSA. It builds on a previous NIHR project from the research group called PROMPT, which was looking at early detection. And in fact, they did a small trial, well, a good-sized trial for its size, looking at the effects on quality of life if you were to do enhanced surveillance in GP practices versus just standard care in GP practices. But again, because it's a rare disease, they didn't have a lot of cases that actually came up in that clinical trial in order to build sort of a predictive model. So our goals in the PREDIPSA project were to develop and compare different machine learning approaches using a large cohort from electronic health records that contain things that can be measured in general practice, so generic symptoms, blood tests, medications that can be prescribed. That's going to be the focus of today's talk. And then our follow-up work that's ongoing is to develop a dynamic model. So this is as you accrue more information over time, be able to update predictions of people's chances of making this transition from psoriasis to psoriatic arthritis. And this particular piece of research is funded by a pharmaceutical company called UCB. Okay, so what is this large-scale electronic health records database? So we're going to use the CPRD, which is the stands for Clinical Practice Research Data Link. So the CPRD contains records from a large number of GP practices spread across the UK, although probably overly focused in England in a relative sense. And it contains clinical observations, prescriptions, blood tests, referrals to secondary care, and some other things. So it's not a design study. This is just patients who come to their GP, look at what the GP would decide to record anyway, and then that can be used for research purposes. So there are definitely some drawbacks in people seek care for specific reasons, and that's mediated by all sorts of facts like their age, their gender, their cultural background. And what GPs decide to actually record in the database will depend on the purpose of the consultation. So I'm going to be interested in, say, back pain, but if someone comes to their GP because their hay fever is out of control, they may not tell them about their back pain, even if they are experiencing it, because that's not the point of the consultation. So it's not perfect data, but it is big data. So in particular, we identified a cohort of about 120,000 patients with newly identified psoriasis. So this is incident psoriasis. So we had evidence, we had an algorithm for determining the patients that we thought were kind of psoriasis free, and then being able to identify, I think this is their first code for psoriasis in the CPRD. And then we followed them forward until either they stopped contributing data, they passed away, their GP practice took themselves out of the CPRD, or they developed psoriatic arthritis. So we have about 2,500 patients who develop psoriatic arthritis, which is about 2% of the group. So even within this cohort of patients for psoriatic arthritis, it should be more common. It's still fairly rare. And again, we had an algorithm for validating whether we thought a case was actually psoriatic arthritis. So a GP could put a record in. So they have a patient with psoriasis. They could put a record in, which is the code for psoriatic arthritis, because they think they have it, and then actually they don't have it. So we had to do some validation, like if someone has psoriatic arthritis, they should have ongoing treatment for some medications to sort of tamp down the immune system. So if they have one code and then no evidence of treatment, it probably is that they don't actually have psoriatic arthritis. Similarly, if we saw a PSA code, but then we saw ongoing codes for, say, rheumatoid arthritis, it's probably more likely that patient has rheumatoid arthritis than psoriatic arthritis, so we wouldn't flag them in our algorithm. Just a little kind of diagram of what in my mind this data looks like. So we've got people who start contributing data to the CPRD. We do have some time window where people have to have data in the CPRD for a certain amount of time before they are considered an incident case of psoriasis. That's because when people join GP practices, sometimes the GPs would just put in all the codes for all the things they have ever had. So we can't tell if that's a new case of psoriasis or just what I would call a prevalent case. So there's sort of some cooling off period, and then you have your first code for psoriasis. We look for some evidence that that's psoriasis. And then they may have some musculoskeletal symptoms like back pain here. They may have some blood tests, perhaps some prescriptions, maybe prescriptions for pain, perhaps prescriptions that indicate their psoriasis is getting more severe. Then we might see a referral and then the first PSA code. This is sort of best case scenario. It's a lot messier than this, but this is the picture that I have in my mind. We have some people who are diagnosed. We have these generic these generic features that can help us build a story for the fact that someone is developing towards a diagnosis of psoriatic arthritis. Okay, so the next couple of slides are going to talk about the two different machine learning algorithms that we use in order to look at this type of data and build a model that can say, with these, put in the top of the model these generic features and come out the bottom of the model probability that you have or you will develop PSA. So that'll be first a random forest, which I think some people are familiar with in this room, but I'll talk about what it is anyway, and then more what we're interested in our group, which is Bayesian networks. Okay, so random forests. So random forests are a pretty popular machine learning algorithm, like it's in most software and pretty easy to implement and pretty fast. Pretty good. So a random forest is a collection of decision trees. So in my mind, I find it difficult to really think about what a random forest is, but I can think about what a tree is. So I'll tell you what a tree is. So a tree is, if you've got your features that you might want to use to predict your outcome, and then you split those features, you cut those features and you find cut points in those features, and you use those cut points to split your data into smaller and smaller groups, so that at the leaves of the tree, you hopefully have a roughly homogeneous group of people in terms of whatever is the outcome that you're interested in. So as an example from this paper, which is about heart disease, we've got our first split is on age. So people who are greater than 60 years old go to the left, and then the people who are younger, they go to the right. And then we have split on, I think it's left ventricle ejection fraction or something like that. We've got that greater than or less than 40, we've got a split there. We can also split on categorical things. So this is just diabetes, yes, no, and then male, female. And then we have, for the younger side, we have a different set of predictors we use to do our split. And then at the end, it's popping out a probability of Class A or Class B. I can't remember what that means, but I think it's like a high and low risk for heart disease. But the nice part about this is that, so I mentioned we've got different predictors on the right-hand side for the young folks and the left-hand side for the older folks, and that's a form of kind of interaction. So it captures these interactions. You don't have to have the same effect, say, of BMI for everyone. And in some of the earlier models for psoriatic arthritis, because the sample size was limited, they weren't able to build in these complexities in their modeling. So random forest can a decision tree can discover kind of what are these splits, which can be differently splitting your predictors on different sides of your tree, which is quite nice. And then for a particular decision tree, you can get this kind of explainable picture, which tells you what were the most important features in coming to the decision about whether a patient was Class A or Class B in this case. Now, a random forest is a collection of these trees. So you have a deck of these trees, and it does some smart things to prevent overfitting. So each tree, it fits on different subsets of the data, and sometimes you can have it fit on different subsets of the features so that you don't get overfitting to one particular thing. And that helps add to its good predictive performance. So like I said, pretty popular. This is kind of our benchmark in our research. What we're really interested in and have done a bit of work on before in the CPRD is something called Bayesian networks. So Bayesian networks are probabilistic graphical models which represent the dependencies between variables using a directed acyclic graph. I'll have an example in a second if that makes no sense to you. This also may make no sense to you until I show you my example. The graph tells us how to factorize the joint distribution. So if you have a large number of predictors in your model, you could try, and you wanted to look at the joint, like the global probability between all of these different features. That would be a lot of relationships to model. But the graph, the edges that exist between them, or let's say the absence of edges between some nodes, tell us that we can sort of ignore those relationships when we want to have an expression for the joint distribution. And we can either specify the graph from expert knowledge, so a clinician can say, okay, I know A causes B, so your graph has to have that edge in there, or you can try to learn it from the data, which is what we do. And these are used a fair amount in healthcare. This is a nice review which just looks at kind of which parts of healthcare are using Bayesian network-based models. And the same research group also has another review paper that's sort of like, why aren't people using Bayesian networks more often? So that's a nice paper if you're interested in these. Both of those papers are nice if you're interested in Bayesian networks in healthcare. Okay, so I said the first few bullets probably don't make a lot of sense, but here's my picture. So this is the ABCD, so we've got 4 things in our graph. And directed acyclic graph, directed means my edges have a direction, they point, they have arrows, and then acyclic means that there can't be cycles. So if I turn this to point C to A, then I'd have a cycle, which is a no-go. And then I said this helps us figure out how to factorize the probability distribution. So if I want the joint distribution of all 4 things, I can start at my node that has no parent, so A has nothing pointed to it, and then B is only pointed to by A, C is pointed to by A and B, and in particular, if I want to write then the final thing, my probability for D here, I don't need to worry about A and B because D is only pointed to by C. So all of the information that A and B could carry about predicting D are kind of coming through their impact on C. So we don't have to, if we want, we can kind of model these local relationships. I can model this local relationship here, and I don't have to worry about the kind of whole big picture. And then the graph tells me how to multiply up these local relationships into the global distribution. In our research, we're going to look at a couple of different types of networks. First is called naive Bayes. So here my circle node represents the thing I actually want to predict. So that, in our case, is psoriatic arthritis. And we've got some nameless, faceless, 5 predictors of that. And naive Bayes says all of those predictors point to the thing I'm trying to, all of my features point to the thing I'm trying to predict. So there's no learning here of the network, it just is what it is. Tree augmented network is kind of similar. Everything has to point to the thing I'm trying to predict, but my 5 features here are each allowed to have 1 parent. So it's like a tree. You can have a few multivariate relationships, but then ultimately the final child is the node I'm trying to predict. And then a sort of more general Bayesian network doesn't make these restrictions, and in particular we can have the thing we actually want to predict, so PSA in our case, can also have sort of downstream effects. And this makes a lot of sense in our situation because we don't know the PSA node, but we can see things that have been caused by PSA, like the symptoms, like the back pain. So it's not that like back pain causes PSA, actually PSA causes back pain even though we see the back pain first. So it makes sense there's sort of upstream causal factors as well as downstream consequences of the thing we're trying to predict. And in our research, we investigated 2 different ways of building this network, this graph. One just takes the whole global big picture, and our circle node is no different than any of the square nodes. And then there's another algorithm on the slide that's denoted MBBC, which first prioritizes learning the relationships around that circle node, and then so prioritizes those first, and then has less influence, cares a little bit less about the stuff going on outside the neighborhood just of the circle node. Okay, so on to results. So these are our predicted performances of the algorithms that we looked at. So random forest, and then the different versions of the trees. So again, MBBC is this kind of look at the local area of your predictor thing you want to predict first, and then taboo is the more general structure finding thing. So our top 2, so for ROC, the best model will be the model that's closest to the top left. So there's some criticisms of ROC curves, especially when you have kind of rare diseases. So looking at precision recall is an alternative which does take into account the prevalence of the thing you're trying to predict. So in our case, the prevalence of PSA in our data set is about 2%. So if the precision is above 2%, that's a good thing. It means we're doing better than random guessing. Here, random forest and MBBC seem to do the best. And I've pulled out their specific quality metrics here. So a random forest is better. We do have some confidence intervals in the paper. It's not, I would say it's not necessarily significantly better. And then, so the best value for the AUC would be 1. So these 2 values I think are pretty good given the quality issues that you're going to have with general practice data. And then the PR AUC is here. So again, the thing to maybe compare to here is 2%. So if we were randomly guessing, we'd have like a 2% success rate. So we're doing a lot better than 2% here, and random forest is definitely doing a bit better here. So looking at what those models can tell us, this is the graph that we estimated from the MBBC. So we had done some previous research with Bayesian networks where we just used the musculoskeletal symptoms, which are in green, so I'm not going to talk about those. The interesting part of this paper was the blood test results that are in the kind of maroon, and then the NSAIDs, which are in orange here. So plasma viscosity and CRP are both generic markers of inflammation, so they're not specific to PSA. One thing we found interesting with CRP is that it actually kind of just matters whether the GP ordered the test. It doesn't actually matter what the test result was, really. And in PSA patients don't necessarily have an elevated CRP. So it might just be the GP is thinking, something inflammatory is going on here, so I'm going to order this CRP. So it's more about telling us about what the GP is thinking necessarily than the actual test result being important. Although we do see the highest risk of PSA was associated with high CRP, but it's not necessarily the case that all patients with PSA will have a high CRP. And then NSAIDs, again, so these are prescriptions for NSAIDs. So not everyone would get a prescription for NSAID because it's like, for me, I pay £9 for my prescriptions. It's just cheaper for me to go to Boots and buy ibuprofen than it is to get a prescription for it. So this is a little bit messy in some ways. But it does maybe, again, mean that the GP is thinking like there's some kind of generic pain thing happening, and so I'm going to prescribe you something. So for example, like naproxen, which you wouldn't get over the counter. So it's not that the NSAIDs are causing PSA, it's that they're a marker for something happening that's out there. We can also look at variable importance. So we did this in a way that was kind of non-specific to the model. So we did something called permutation variable importance, where you take a predictor and then you scramble it and then refit the model with one of the columns scrambled. So you basically broke in any interesting relationships that are happening, refit the model, and then the change in the predicted performance tells you how important the predictor is. So we have NSAIDs as important and CRP is important. One thing that's interesting here is that psoriasis duration is really important. And here, because we have GP practice data, it's actually not like risk goes up as time goes on. Actually, there's really high risk in the first year after you're diagnosed with psoriasis, which is probably just you have PSA and your GP has picked up the PSA and the psoriasis at the same time. So it's kind of, you're getting a coincidental diagnosis rather than, so it's maybe an artifact of the type of data that we have here, I would say. Okay, I'm going to skip over the key takeaways in the interest of time and just go to what will be our next steps. So the analysis today presents one big flaw is that we ignored the timing of the symptoms entirely. So if someone has psoriasis and then back pain 6 months later and then nothing for a very long time, that person looks the same in the data set in terms of what we fitted as a person who has psoriasis, nothing for 6 years, then back pain, then a PSA diagnosis, which is clearly a flaw. And we want to use something where we can update the predictions over time and take into account the timing of those that could vary information. And we're planning to use something called landmarking, which looks kind of like this. So you have your psoriasis diagnosis, you have data collection up to some pre-specified time point, maybe it's 2 years or something, and you look at predictors in that window, then you can do your prediction, what's the chance of developing in the next 5 years, and you can do this in kind of rolling windows. And this has been used in cystic fibrosis. It's been used in predicting cardiovascular events. I think it's gaining popularity, and it also allows you to plug and play in exactly the type of model that you do in each prediction window. So it's quite flexible in that way. And we're working on developing a version of landmarking that uses Bayesian networks to do this time-varying prediction of psoriatic arthritis. Okay, so that's it for me today. If you want to see more about the details, the paper was recently published in Annals of the Rheumatic Diseases. That's Alex. He's my PhD student who's just about to submit his PhD. Like, I think he'll do it next week, so I'm very excited. He did all the work. These are his two co-supervisors who are rheumatologists. UCB funded this work, and as Pao said, I'm part of the AI for CI hub. I'm one of the theme leads for healthcare ecosystems, so maybe you'll see me around Bristol a bit more, at least for the next 5 years. All right.